Good afternoon, everyone. Welcome back to Medflix 2021 virtually from the comforts of your home and practice. The topics that we will be discussing now will be combating CINV with Granisetrons. My name is Jun. I will be the moderator for these sessions. Before we proceed, please remember to check in at the top left button so that we can record your attendance for the CPT points. We have few housekeeping details to go through with you. The live stream session today will work based on the webinar format. If you have any questions during the talk, there's a button present which you can click to submit a question. The questions will be directed to the session moderators, to the speakers to discuss if the time permitted. Our speaker for this session is Dr. Marwinder Singh, consultant clinical oncologist from Sri Kota Specialist Medical Centers. Dr. Malwinder earned his medical degree from Manipal Medical College. He completed his master in clinical oncology in the University of Malaya. Dr. Malwinder had actively participated in various clinical trials where he has involved in various drug trials in the fields of gastro, breast, lung, renal, and pancreas. His work has been published and presented in various conferences which advance our understanding in cancer management. Dr. Malwinder has presented no less than 30 talks to the healthcare professional in the past 3 years, and he has invited numerous times, either in the radios and TV, to raise the cancer awareness. His insight in the management of nausea and vomiting after the chemotherapy can offer good tips how to improve the cancer patient's quality of life. Please welcome Dr. Malwinder.
Thank you, Jun, for a kind introduction. Okay, so my topic for today is for combating CINV with Granisetron. I know it's the last talk, so please bear with me. I'll try to make it as simple as possible. Okay, so what is CINV actually? A long abbreviation for it is chemotherapy-induced nausea and vomiting. So there's three elements in chemotherapy-induced nausea and vomiting. One is nausea, where you have the sensation or the need to vomit. Okay. Next is retching. It's a synchronized spasmodic motion of the respiratory and the abdominal muscle before or during vomiting. Next is vomiting, the expulsion of gastric content through the mouth. So this is the scientific definition of CINV. But what is our local Malaysian definition of CINV? So we see a lot of our cancer patients, our uncle and aunties, with different races. They'll come with all these different synonyms for CINV. Some will say it's muntah. Some will say loya, pening, kepala pusing, mual, angin, or ow for Chinese patients. So there are various definitions available for our local population. So it is very important for us as doctors to actually elicit the definition of each of their symptoms. Okay, what is the problem with CINV actually? It is the most adverse event which is experienced by cancer patients. I'm sure most of you have seen cancer patients, and most of them are very afraid with chemotherapy because first thing which comes into their mind is always rambut gugur or vomiting. Vomiting is always perceived as one of the major side effects of chemotherapy. Okay, so when people have CINV, always the main problem is actually it affects their quality of life. They can't take care of their children, they can't do their jobs properly, they can't go out and socialize, they're just cooped up in their home, lying down on their bed, resting. So that's not quality of life. When someone goes through chemotherapy, we want to try to make them to maintain their good quality of life. Okay, so this is actually a study which was done by major pharma company, which was published in 2002. Okay, this study took many oncologists and they actually asked what is their perception and what did they expect for the patient to actually have nausea and vomiting. Okay, nausea and vomiting can be divided between acute and delayed. I'll discuss that a little bit more later on. Okay, so they took the oncologist, they asked what they expect, and then they interviewed the patient and get the data to see whether does it correspond with the oncology expectation. So in any acute setting, the oncologist think that the patient will have 23% of nausea and 13% of vomiting. But however, in reality, the patient actually experienced double the amount. 47.1% had nausea and 28% had vomiting. Okay, so oncologists can be wrong in percepting that the patient will not have CINV or very low risk of having CINV. What about delayed vomiting? The oncologist thinks that 24.3% have nausea and 15% has vomiting. But in reality, 52.9% of patients have nausea and 38.8% have vomiting. Okay, this shows that actually we are very wrong in percepting what is nausea and vomiting for a patient. Because for a patient, everybody is built differently. Not one patient will be the same with the next patient. So the treatment need to be individualized. So that's why nowadays in cancer therapy, every treatment is individualized to a certain patient. We don't treat everybody with a blanket chemotherapy or with a blanket drugs at this moment. So what is the pathophysiology of chemotherapy-induced nausea vomiting? So the drug has two pathways of action. One, it acts directly in the brain, where it triggers your chemotherapy trigger zone or your vomiting center. Or the next one, it actually affects your gastrointestinal tract, okay, where they release the serotonin, which binds to the 5-HT3 receptor, which will activate your chemotherapy trigger zone and activates your vomiting center, which cause increase in salivation, increase in respiratory rate, pharyngeal and GI and abdominal muscle contraction, and subsequently vomiting. So there's two pathways. Okay, so who are the people who are actually at increased risk of developing CINV? Majority, it depends on the chemotherapy regime. There are almost about like 100 drugs of chemotherapy. So certain drugs with certain dose, certain type and the schedule will affect the patients having CINV. And then the next, if the patient is very anxious, we have a few patients, the moment they're diagnosed of cancer, they become very anxious, or some with background history of anxiety. So they tend to get more nausea and vomiting. Okay, and some people who are actually a little bit older or much younger than 30 years old are at increased risk of having CINV. Females, history of alcohol intake, history of motion sickness, history of pregnancy-associated emesis, history of poorly controlled emesis in a prior chemotherapy regime. These are all risk factors for having further CINV. Okay, are all CINV the same? The moment patient come and say, oh, saya muntah lepas chemo, I have vomiting, I have headache, I have nausea. So what does it mean actually? As a doctor, we need to know what kind of vomiting they have. Okay, there are actually a few kinds of vomiting. Okay, one is an acute phase vomiting, where the moment they have their chemo, within 24 hours, they have nausea and vomiting. Okay, and this is usually worse during the 5 to 6 hours after chemo. This is acute. And then you have delayed chemotherapy-induced nausea vomiting, where it happens after 24 hours of chemotherapy. There are certain notorious drugs like platinum or cyclophosphamide or anthracyclines, which can cause delayed nausea and vomiting. Okay, and this can actually last longer, sometimes up to a week after chemotherapy. So that's why sometimes some patients will say, I did chemo today, I only had vomiting for 1 day. Some patients say, I had chemo today, I had vomitings until 7 days also. It's because it's a different kind of vomiting. And it's very important to elicit the kind of vomiting because the drugs to act on it is actually different. The next one is anticipatory vomiting. This occurs when the patient already had like a few cycles, one cycle or a few cycles of chemo, and they experience some bad side effects. And then before they go for their chemo, like 1 day or 2 days before, they already anticipate that they're going to get a lot of nausea and vomiting. And it's a psychological process where they start vomiting even before the chemotherapy is being given. Okay, so this certain particular group of people, which is very important because this kind of anticipatory nausea and vomiting will not work with your traditional vomiting medicine. There's a separate drugs which you need to give for people who are having anticipatory vomiting. Another one is a refractory vomiting. Unfortunately, for these groups of patients, they have like 1 or few cycles of chemotherapy regime and they've been treated massively with a lot of anti-nausea and anti-vomiting treatment. But unfortunately, it still doesn't work for them. They still have a lot of nausea and vomiting. These are the refractory kind of groups. Okay. The fifth and the last one is breakthrough. It can occur during any time of your chemotherapy cycle, even on day 1 or the subsequent days or whenever, and even when you're already having optimal antiemetic prophylaxis. Okay, so these are breakthrough. Anytime it can occur. So this is a rough graph where it shows anticipatory happens the day before your chemo. Day 1 is the day of your chemo. Okay, up to day 2 is considered acute because it's within 24 hours. Okay, anything beyond day 2 onwards is delayed, and breakthrough is day 1 onwards until you go for your next cycle. Breakthrough chemotherapy-induced nausea and vomiting. Okay, so selecting antiemetic regimen for chemotherapy-induced nausea vomiting. Chemotherapy agents are classified based on their ability to cause nausea and vomiting. There's a risk category like low, moderate, and high risk. Okay, the hematogenicity of a chemotherapy regime is based on how hematogenic the drug actually is and what combination are you using. If you're using a single drug, probably it's not much CINV, but if you're using multiple drugs, which most of the regimes are nowadays, the chances of having CINV is going to be increased. So this is actually a chart where it was published in ESMO. ESMO is European Society of Medical Oncology, which most of us as clinical oncologists follow them as a guideline. Okay, so there are many drugs of chemotherapy, targeted therapy, monoclonal antibodies, immunotherapy, and all, where they classify between high, moderate, low, and minimal. Okay, so from this high, moderate, low, and minimal, then we devise our strategy how to combat CINV. Okay, and these are oral neoplastic drug, something like your targeted therapy. Okay, so targeted therapy also has minimal, low, moderate, and high risk of having chemotherapy-induced nausea, vomiting. Although the term chemotherapy CINV is there, but in reality, that chemotherapy actually consists of all anti-cancer drug, which is chemotherapy, immunotherapy, targeted therapy, or whatever different regimes which there is at this moment. Okay, so this is ESCO guideline. It's the American Society of Clinical Oncology. Okay, so even they have categorized between minimal, low, moderate, and high. Okay, and majority they've divided between acute and delayed. So acute is day 1, delayed is day 2 onwards. Okay, in any of those group, okay, except for the minimal group, okay, most of them will always have 5-HT3 antagonists. Okay, which is also known as drugs like ondansetron, granisetron, or palanosetron. Okay, and then if the higher the hematogenicity rate, then you have to add on more drugs. For something minimal, probably you don't need anything. If like low risk, you can add some steroids and just 5-HT3. If it's moderate, you have to add steroids plus 5-HT3. Okay, and then if it's high, 5-HT3 plus steroids and plus NK1 antagonist. I'll discuss more about all these different groups later on. Okay, same goes for delay. If it's minimal, probably nothing. Low, also nothing. Moderate, you give some steroids. High, you give dexamethasone plus NK1. Okay, and then they went a step further where they add on a new drug called Olanzapine. Okay, Olanzapine is actually a very good drug which I've realized for actually combating chemotherapy-induced nausea, vomiting. So someone who's actually having a very high hematogenicity chemotherapy, you can use Olanzapine as acute and also delayed. Okay, and for moderate risk, if you're using carboplatin is mainly a platinum group, which is a backbone of most chemotherapy regime. You can always add an NK1 receptor. Okay. Okay, these are the drugs which is actually available in Malaysia and the dose which you're supposed to use. If you're talking about like 5-HT3 antagonists, you have Granisetron, which is also known as Skytril, and you have Ondansetron. So Granisetron, mainly if you're using intravenous, you can use 1 mg or 3 mg. There are some trials to show, majority of the trials shows actually 1 mg is equivalent to 3 mg. Okay, but 1 ampule comes in 3 mg. So you can use it, either dose is okay. If you are using oral, the tablet comes in 1 mg. Some use it 1 mg OD, some use it 1 mg BD. Okay, Ondansetron, roughly about 8 to 24 mg and 16 to 24 mg for IV and oral respectively. If you're talking about steroids, most chemotherapy regime as a pre-medication, you're using about 8 mg of steroids IV before you give your chemotherapy. Some very highly hematogenic drug probably will give like 12 mg. Okay, and then Maxilon, you can give 10 to 20 mg either IV or oral 3 times a day. Okay, next is like Lorazepam. Lorazepam is actually one of the drugs which we use for anticipatory vomiting. Okay, you can use 0.5 mg to 2 mg per oral. You give it like probably 2 days before or 1 day before, or during the day of your chemotherapy, you can still give the Lorazepam. Okay, and then Prochlorperazine 10 mg, haloperidol 0.5 to 2 mg also, or Aprepitant, which is an NK1 antagonist, 125 mg day 1 and 80 mg day 2, day 3. Okay, so what is this 5-HT3 receptor antagonist? The drugs which is available in Malaysia at this moment is like Granisetron, Ondansetron, and Palanosetron. Okay, it's used principally for acute nausea and vomiting. It's effective in significantly increased when used combination with dexamethasone. When you add on 5-HT3 with steroids, it actually helps much more compared to just using it as a single agent. Majority of my patients and most chemotherapy regimes in a few centers which I've worked at, most of them basic drug, they always use Granisetron because it's a very cheap drug and it's a very powerful drug to control chemotherapy-induced nausea, vomiting. Okay, and it's used mainly for acute nausea, vomiting within the first 24 hours. Okay, it's the same thing what I've mentioned earlier on. Palanosetron is a new generation of antiemetic 5-HT3. Okay, in Malaysia at this moment there's only intravenous. So some people who are actually on Granisetron which don't respond very well, probably you can increase to Palanosetron. Okay, having higher doses than this doesn't improve the outcome. Okay, what about NK1 receptor antagonist? Okay, there are drugs like apripitan and fosapritan. In Malaysia, there's only apripitan. The dosing is first day 125 milligram on day 1. Subsequently, day 2, day 3 will be 80 milligram. And this drug, the first day is all given 1 hour before your chemo. And this drug is actually very good and very useful for using for acute and delayed emesis. So it helps in the first 24 hours, and it can actually carry on for the next 5 to 6 days to control your chemotherapy-induced nausea, vomiting. Okay, it's very well tolerated. It's just an oral drug. Some of the side effects, it can cause some asthenia, fatigue. Some people complain diarrhea, some people complain constipation, nausea, dizziness, and also some hiccups. Okay, corticosteroids dexamethasone. It is one of the very important drugs in oncology because we tend to use it for many different reasons, and one of it is actually for CINV. Unfortunately, the mode of action is still unknown. It is effective as a single agent and increases efficacy with 5-HT3 antagonist. And it can be used for both acute and also delayed. So if a patient's coming for chemotherapy regime, part of their regime pre-medication, we give IV dexamethasone. And on discharge, we will give them 3 days minimum of tablet dexamethasone. So in case if you're a GP, you see patients coming back subsequently with nausea and vomiting after their chemotherapy, okay, you can always give them some steroids and something like Maxolon also. It helps a lot. Okay, for short courses, you don't need to taper the dose. Like traditional teaching, when you're using long-term steroids, you need to taper the dose, but just for 3 to 5 days, and you don't need to monitor any blood markers also. But the only problem with giving steroids, it causes some mood elevation, it can cause some gastritis, it causes some energizing effect, appetite stimulant. Some people become irritable, insomnia, and there's loss of glucose control. My main problem of giving a lot of steroids is actually maintaining gastritis. So whenever we write dexamethasone, we need to give some proton pump inhibitors together with the dexamethasone. Okay, and for diabetic patients, we really need to monitor their glucose control. That are the 2 main problems which I face actually when I use dexamethasone. Okay, next group is the dopamine receptor antagonist, where simple drugs like Maxolon, domperidone, haloperidol, and olanzapine. The side effects is like sedation, EPS symptoms, dystonia. Okay, mainstay of the anti-emetic therapy for highly emetic agents in the days before 5-HT3 antagonist. Those days, long time before, we were just using these basic drugs. Then when came 5-HT3 antagonist, we started using that and we saw far more better results compared to just using these simple drugs. Okay, it's used principally in breakthrough nausea and is given intravenous. You can also try oral medication also. Okay, olanzapine is actually very newly incorporated into the ESCO and NCCN guidelines. Okay, because there's new trials which shows there's actually much better maintaining your CINV so that you don't have a lot of this problem. It is used mainly for prophylaxis for platinum group and your cyclophosphamide and doxorubicin, which is majority used for breast cancer patients. Most 99% breast cancer patients will use cyclophosphamide and doxorubicin. And you can combine it with NK1 receptor and 5-HT3 antagonist and steroids to get the maximum benefit. Okay, and the drugs is actually very cheap. It's just few cents per tablet. Okay, higher proportion of patients with no nausea, improved complete response rate, no nausea, and you don't need no rescue medication also. You can use 10 milligram per day for the first 4 days or 5 milligram also if you're worried about sedation. Okay, benzodiazepines like Lorazepam. It's a primary agent used to treat anticipatory nausea and vomiting. Simple like 0.5 milligram is sufficient. Give it the night before or 30 minutes before chemotherapy. It's used for acute and breakthrough emesis. One of the side effects is you can be a little bit sedated and there's tranquilizing effects. Okay, so those are all about drugs which we use. Okay, but what about some other things which we can add on to maximize the benefit? Okay, something like diet related. When someone is having a lot of chemotherapy-induced nausea, vomiting, we can always tell them to eat small but frequent meals versus eating a very large meal. Eat the largest meal when they feel very less nauseated. Eat room temperature food so that it's less aromatic. Try to avoid sweet, salty, spicy, fatty, or aromatic food. Okay, do not eat for 1 to 2 hours before treatment if nausea and vomiting occurs during the treatment or within few hours of treatment. Generally, I don't tell my patients to come for chemotherapy fasted. They just come as normal because most people don't complain much of this. But if say I have some patients who actually have a lot of vomiting few hours immediately after chemo, okay, the acute vomiting, so then I would tell them try to reduce your oral intake. The main problem with CINV, from what I face, is actually the delayed vomiting. The acute vomiting generally is not much of an issue because that's a time where they're in the hospital for their drug, where they get all their Granisetron, they get their Maxolon, Dexamethasone, their PPI, so everything is very well managed. The only problem is when they go back, because most of nowadays chemotherapy regimes are all as daycare and outpatient basis, where they come morning and then afternoon they go back home. So what happens at home, that's the problem, and those are the one which is the delayed vomiting. So if a patient's having delayed vomiting and actually present into like to A&E or present to a GP or something, you can try something very simple like Maxolon, Dexamethasone. If it's not responding, then it needs to be given intravenous, okay? Or some like some sedation effect also, probably can get some haloperidol or Lorazepam to try to calm them down. And then try to advise them for these lifestyle modifications. Okay, if you experience CINV, you can use some fix or nutritional supplement. Nutrition is very important for a patient who's actually undergoing chemotherapy. Okay, they're not going to eat much, so try to supplement them with some nutritional drinks like shakes or even like some products by different company which have all the formula inside specific for cancer patient. Keep some crackers or bread within reach. Increase your fluid intake. If you can't eat, make sure you're drinking, and try to drink nutritious drink instead of just drinking plain water. Okay, drink clear fluids, fruit juices. Try to sip slowly, small amount but frequent. Try to make some popsicles, jello, frozen fruits, ice chips as a source of fluid. Okay, so that's mainly for CINV. Okay, now we do radiation also, and radiation also can induce emesis. And even in radiation also, we have classification like minimum, low, moderate, and high. Moderate and high generally is mainly for the hematological malignancy, where we do total marrow irradiation, or we do a craniospinal axis radiation, where the whole brain up to your whole spine gets radiated. The one which most of a solid tumor gives radiotherapy is like brain, head and neck, thorax and pelvis, or like extremities and breast. Okay, so if you're having a high hematogenicity rate, like for total body radiation, you can still use Kytril. Granisetron, you can use Dexamethasone, you can use it as a prophylaxis the day before, the first day, and the second day. Okay, and this is actually one study which was done, published in 1995 for hematological patient, where they actually shows that is significantly better control of nausea and vomiting in the Granisetron group after radiotherapy, where 53% of complete response versus 13% of complete response for population who just had Maxolon, Dexamethasone plus Lorazepam. So Granisetron is almost 5 times better compared to just having a basic metoclopramide or Dexa and Lorazepam. If you are moderate risk for like craniospinal or any abdominal radiotherapy, especially for us in solid tumors where we treat spine metastasis, something which involve your thoracic vertebra up to your lumbar vertebra, that's considered moderate because your radiotherapy beams will be, the exit beam will touch your bowels, your intestines and all. So you do get the radiation side effects from it. So you can use something simple like Granisetron or even some steroids, where you can use it the day before or each fraction of radiotherapy. But the problem with craniospinal is normally like 4 to 5 weeks of treatment, so you can't be giving steroids for very long term. So you can give it initially and then subsequently just maintain it with Granisetron. So all of this normally we give it like half an hour before we give our radiation. Okay. So this is a chart, the efficacy and safety of once daily Granisetron for prophylaxis of nausea and emesis following fractionated upper abdominal radiotherapy. So as you can see, for someone who just had like 1 fraction compared to, as the time passed, 10 fractions, 20 fractions, you can see that Granisetron chart is much more above compared to the placebo group, which shows that having Granisetron actually controls your nausea and vomiting during your radiotherapy treatment, because radiotherapy treatment is not like chemotherapy where you just have 1 cycle and then you rest for 3 weeks or 2 weeks. Radiotherapy is going to be something continuous for daily, and you only rest like 2 days per week. Something low like brain, head and neck, thorax and pelvis, you can use Kytril, you can use Dexamethasone, you can use Maxolon. For me, most of my patients, I just use Maxolon and steroids. I hardly use Granisetron because this is extremely low to cause any nausea and vomiting. Okay, even for extremities, breast, or even your hands and limbs, the guideline do recommend giving Granisetron, steroids, or also Maxolon. But generally, most of these patients don't need anything. But even if say you need it, just use it as rescue. Whenever they have the problem, then you give it to them. Okay, so this is actually a guideline. This is our local Kementerian Kesihatan guideline. This is a guideline from Journal Clinical Oncology. We have guideline from ESMO also. There are many guidelines. Okay, but the problem is actually the biggest barrier is poor adherence to the existing guideline. Okay, a lot of our patients are not receiving adequate anti-emetic based on the guidelines. There's a study done by Pan-European Emesis Registry. It's a prospective observational study where they found 55 to 46% of patients only receive guideline-consistent anti-emetic therapy in the acute and delayed, respectively. Okay, almost half is receiving guideline. The other half is not receiving anything. It's just like the oncologist do shock surgery saja. Okay, and only 29% of patients in this study received guideline-consistent anti-emetic therapy for the entire study period. Such a small population. So where are we going wrong with this? That's all for my presentation. Is there any questions which I can take?
Thank you, Dr. Malwinder. That's a very interesting talk, Sam. So it seems like battling the cancer itself is a very tedious process. So I'm quite sure that any efforts in reducing the side effects of chemotherapy and radiotherapy will be appreciated by the patient. So if you have any questions, please key into the chat box. We have a couple of questions that are coming in already. I can start asking Dr. Malwinder then. So
sure.
The first question is actually quite interesting, talking about chemotherapy-induced diarrhea. And so the question is the activated charcoal will be able to help these groups of the patients?
Okay, even diarrhea, right? There is acute and delayed phase diarrhea. Same definition, acute is less than 24 hours, delayed is more than 24 hours.
Yep.
Okay, acute diarrhea, right? There are some regimes like a drug called irinotecan, which we give for colorectal cancer, where we actually will give subcutaneous atropine as a pre-medication before we give our chemotherapy. Okay, so that's mainly for acute.
Yep.
Delayed phase diarrhea, okay, the only drug which actually, this is my personal experience, the one which I feel the best to control chemotherapy-induced diarrhea will be something like loperamide. Then comes Lomotil. Charcoal is mainly like to remove all the gas secretion which they have. Like some people when they have diarrhea, they have a lot of abdominal bloatness. So charcoal tends to help in that. But none of my patients actually, long time ago, I just tried charcoal alone. It doesn't really help in your diarrhea.
I see.
You need something like loperamide or Lomotil, and then even that also, some people are really quite bad. Like some people who do radiotherapy to the rectum, so their bowels are in the radiotherapy field. Sometimes you need combination of loperamide and Lomotil also.
Okay. Thanks, Dr. Malwinder. So the next question here is actually related about the drug use. So this patient already taking a daily doses of prednisolone. So the question is, can the prednisolone replace the roles of dexamethasone as the antiemetics?
Yeah. So there are some patients who like having autoimmune disease where they are already on long-term prednisolone. Okay. So I normally don't give dexamethasone because the function is the same. Yep. Although Dexa tends to be more potent, okay, but since you're already on prednisolone, I just continue the daily prednisolone dose. I don't change the dose of prednisolone also.
Sure. Thanks, Dr. Malwinder. Okay, the next one is this is a question on the dexamethasones. What is the dose of dexamethasone should usually prescribe to the patient, and how long you will put them onto the dexamethasones?
Okay, as part of most chemotherapy regimes, standard we give IV 8 milligram as a pre-medication. There are some where we go to 12. There are some regimes where we go up to 20 also, IV. Yep. Okay, this is to reduce the anaphylactic reaction for some of the drugs. Okay, and then once when they go back home, we give them 8 milligram daily. So most of us will break it up into 4 milligram BD for once morning, one night. Okay, we give it minimum for 3 days. And then make sure when we give this dexamethasone, we need to give some proton pump inhibitors. And the night dose, we always tell patients to try to take it before 6 p.m. Although it's BD, don't take it after 6 p.m. because steroids cause insomnia. So then some patients will kind of tell you, I cannot sleep after chemo.
Okay, so it seems like if we fix one of these nauseous vomiting problem, then we may give them the insomnia issue if they take it too late.
Yes, correct.
Okay, the next one is, do you still use metoclopramide and domperidone concurrently in your clinical practices?
I actually don't use domperidone. I only use metoclopramide. If say someone needs something more than metoclopramide, then I normally add Granisetron. Even Ondansetron, I hardly use because I can speak for myself and some of us lah. Most of us during our oncological training, right? Most of the chemotherapy regimes, even in clinical trials and all, mainly use Granisetron.
Yep.
So we are more comfortable using Granisetron than Ondansetron. Not to say Ondansetron is not good, okay, but something which you're comfortable, you tend to use it much more.
Okay, thanks. So then the next question is actually related to the serotonin receptor antagonist. So what would be the advice you offer to the user here? How to choose the serotonin receptor antagonist given to the patient then?
Okay, I think most of the audience, either someone who's working in a GP or other specialty and all.
That's right.
So I think most of them will come to you as outpatient.
Yep.
So if you have something from outpatient, you can use something oral, like your Granisetron or Ondansetron. Okay, but you say they are not doing very well, where you need to admit them to the hospital, then you can always change it to the IV medication. And one thing, when we use all these very bombastic nausea and vomiting drugs, right? Once when the symptoms already reduce or stop, it's always advisable to stop your serotonin receptor antagonist, because having long-term treatment of all of this, right, will tend to cause constipation.
Yep. Okay, so even though the drug might be effective in managing the nausea and vomiting, but we use it long-term, constipation is the next thing that we need to worry about.
Yes, correct. You use a lot of new combinations of antiemetics and all. A lot of patients will come back and say, "Doctor, I cannot pass motion for the next 3-4 days," when they are taking all this medication for delay. Once the second week after your chemo, then they feel much better. They can pass motion normally.
Yes. All right, so have to look at the totality actually.
Yes, everybody is different. So when you see a patient the first time, right, you can go by guideline. Guideline mention ABC, so you follow everything. But as time passes by, when you see your patient, you know your patient, you can always adjust a little bit here and there. Sure. Because not everybody require very high antiemetic. But some patients are really very like those isolated ones where you require a lot of antiemetic. So it's a trial and error. You can go by guidelines, but ultimately it's a personalized decision.
Yes. So I do have a questions regarding the guidelines since that were mentioned about it, because according to a guideline, let's say the patients is having a high hematogenic types of nausea and vomiting, and then based on the guideline, you need to give them a triple therapy and then followed by 2 more drugs during the delay phases. What if during the acute phases the patient having a breakouts of nausea and vomiting? What would be the strategy? Will you be replacing the drug, or will you be adding in the drug during that periods of time?
Okay, so even with having this triple regime for, like, say, for example, breast cancer, somebody who's having erythromycin and also cyclophosphamide. So a standard regime, what we give is like we give something like NK1, plus we give 5-HT3, and we also give dexamethasone and Maxolon. Okay. So this is for acute and delay. So say, for example, if a patient comes that day during chemo, okay, during chemo itself, they have like some episodes of vomiting. Okay, you can always just add on some IV Maxolon. Or if you find like they are a little bit anxious, some patients at home, they are very well, but the moment they come to the hospital, they get a little bit more anxious. So when you're a little bit anxious, you can always like give them some Lorazepam, some haloperidol during chemo also. So there are some oncologists, part of their chemotherapy pre-medication, they do give some of this haloperidol or Lorazepam to calm the patient down.
I see.
So when they go back home, then standard is like your metoclopramide, your dexamethasone, and also the NK1 receptor for the next 2 days. But in case if they have some more nausea and vomiting, you can always prolong your metoclopramide usage, or you can steroids. You can still continue, but normally most of them will start subsiding with just metoclopramide. Or even you can sometimes just add some 1 or 2 doses of Kytril after discharge also.
Sure.
So it's always playing around with the regime.
Sure. Thanks, Dr. Malwinder. So the next questions, right? This is actually related though to those patients who may not be well controlled when they're under the drug treatment. So in case after the patients are taking the drug, then they still have these too much of vomitings, right? Should these patients go to the hospital for fluid drip, or they just go with the oral rehydration salt if they're having the vomiting? Okay.
In any patients who have chemotherapy or any drug for anti-cancer drug, okay, there's always like some 3 to 5% of patients who really cannot tolerate the drug which you're giving. They have a lot of vomiting. Okay, then first thing you need to think back, as an oncologist, we need to think back whether does the patient really need a very high-end drug like this. Okay, then you need to look at the intent of your treatment. If you're talking like a radical intent, you're giving chemo to cure the patient, compared to someone who you're giving chemo just to control the disease, which is palliative. Okay, if something radical, then of course we will try to maintain the dose. and we try to do other things to reduce the CINV. But if it is palliative, ultimately palliative chemo, we want quality of life. So by doing chemotherapy and you're just vomiting away, that's not quality of life.
Yep.
So then you need to think back whether you are using the right drug, whether you're using a very high dose, or should you reduce the dose. So you need to adjust the drug, the chemotherapy itself first. Okay. Yep. But of course, there are certain level of dose reduction which we can accept. If it's already reducing a lot, then of course you can't reduce the dose much more.
That's right.
Okay. So then from there on, then we see what we need to do. After using all traditional medicine which is available to us in so-called scientific term lah, okay,
yep.
There are always other things what patients can do. There are, like when I was working in Johor, some of our patients we normally refer to the TCM group for acupuncture. So acupuncture actually really help for chemotherapy-induced nausea and vomiting also.
So it looks like even the traditional approach may be helpful for the patients as well. That's interesting, actually. Yep.
We try to make the treatment holistic. So whichever thing which can help the patient, of course, we will advise. But of course, don't go for traditional treatment to take orally lah. That one will catch up with the chemotherapy.
Sure.
Acupuncture is okay for pain, for nausea, vomiting. It actually helps.
Well, this is actually quite an interesting question that asked by the audience. So the question is why there's such a low adherence rate to the guidelines, which can translate to unnecessary suffering from the cancer patients. I guess that this is to ask about your perception, why the adherence rate is so low when they come down into following the guidelines.
Okay. Main thing what I can say is always cost. The cost issue. If you're talking about Granisetron is very cheap. So Granisetron, like I mentioned, one IV vial is 3 milligram. You can divide it into 3 patients. The efficacy is the same. So you save cost in that. Okay. Or even you give oral, it's just like berpuluh ringgit only lah. Okay. You say you want to go for your NK1 antagonist. Okay. NK1 treatment will roughly cost you about $200. If you're going for combination therapy, like something new like the Archangel, where it's combination of Palanosatron and your NK1 together, those tablets will cost you roughly about 300-400 ringgit. Okay, but the drugs to give your chemotherapy, majority of chemotherapy drugs nowadays are all generic. The chemotherapy drug itself will only cost you probably less than 1,000, but you're using like 300-400 ringgits of antiemetics just to control the vomiting. So a lot of patients normally they will choose to spend the money on the chemotherapy rather than spending the money on the antiemetics.
Okay. So it seems that price will be an issue. So because they probably spend quite a lot of money on the drugs, on the chemo drugs already, and then to spend even more to stop the nausea and vomiting. Well, but we have to, I guess, that we still need to remember that spending the money in nausea and vomiting is still important to a certain extent because with poor control of nausea and vomiting, that could reduce the compliances as well. So we can.
Another thing, that's why we thank people like you, June, for giving us sample of drugs.
I didn't give a lot, so to make sure that I meet the compliances. The next question is also quite interesting because we know that the introductions of the Olanzapines in managing the nausea and vomiting only started just couples of years ago. So this question is like, can the Olanzapine to give together with the metoclopramide for long-term basics?
Okay, all these drugs for CINV, right, is actually not for long-term basis. It's all for short-term only, because when you give long-term, right, you get all the extrapyramidal symptoms, you get constipation, a lot of different toxicities will start coming up. So give it whenever necessary only. Olanzapine is actually a very, very good drug and is very, very cheap. It's I think one tablet costs less than RM1 also. Okay, and Olanzapine you can use it for acute and delayed. So most of my patients nowadays, I even like something like moderate or high, I will just give them Olanzapine, and it actually helps a lot. So yes, you can combine with metoclopramide if it's like patient having a lot of vomiting, but of course use it for short duration only, not very long. Most of my patients, I think the longest I've ever given any antiemetic to be taken back home is probably about 5 to 7 days. I've never crossed beyond 7 days for any of those drugs.
Sure. So because I used to manage the Olanzapine as well, so I know that is to a certain extent, so quite a number of doctors, it sounds like antipsychotic drugs. So when let's say if you put the patient on Olanzapine, so what are the things to look up for then, based on your experience?
Okay, generally, if you look at the guideline I mentioned before, they did mention that you need to use 10 milligram, and then you reduce to 5 milligram if there's a lot of sedation effect. Okay, generally, most of my patients, I just use 5 milligram.
Yep.
Okay, I mean, I don't have any studies to say that 5 is equivalent to 10, but from my own experience, 5 milligram already do the job already. Okay, one of the long-term problem you continue with all of this is, one is your sedative effect and your mood swings with Olanzapine.
Yep. Okay, thanks, Dr. Malwinder. So the next question here is actually related about the colon cancer. So this question is like, how long will the diarrhea stop after the treatments or the chemotherapy for those colon cancer patients?
Wow, that's a challenging question. Okay, ultimately it depends on the patient. Okay, so acute diarrhea will normally stop within 24 hours. Delayed diarrhea can continue beyond. And we need to see what is the reason for the diarrhea also. The cancer itself can cause diarrhea. Okay. Second thing, if you're giving some chemotherapy drugs like irinotecan, that can cause diarrhea. So some people can go on up to like 1 week. Okay. There are some drugs like if you're giving two drugs which cause diarrhea, the major toxicity of the drug is actually diarrhea, and you're using a combination of both drugs, something like Xeloda and irinotecan, then that diarrhea can continue throughout. It just continues as long as you're on chemo, it will continue every day. Okay. Some patients who are going for radiation, if you're giving radiation to the rectum, or even some gynecological cancer, you're radiating the uterus or the cervix, your bowel gets into the way, so you get diarrhea continuously every day. Okay. So some patients, even who are on this long-term problem, mainly I would say is radiation patient, where they have diarrhea almost daily. So those patients will actually take their Lomotil or Lopromide daily until they finish the whole 5 weeks of radiation. Okay. So generally what I tell my patient is, you say you go back home, you have some diarrhea, 1-2 times loose stools, that is fine, no problem. The moment you hit more than 3 times loose stool in a day, you need to take some diarrhea medicine.
I see. Sure. Okay. Thanks, Dr. Malwinder. So the next question is actually, it's quite interesting that we're looking into the drug for the nauseous and vomiting. We have the choice of IV and tablet. Can Dr. Malwinder share with us under what circumstances you choose the IV and what circumstances you go for the tablet options then?
Okay. For me personally, I don't have any preference. Okay. IV and oral to me is almost the same. There's no issues with it. Only problem is it depends on the patient. If some patient where they have a lot of vomiting, the moment they take something orally, they start vomiting it out. Then there's no point you give something oral. Then they need to go for IV injection. So most of the pre-medication when we give for chemotherapy, generally we use it as intravenous. Then whatever drugs they go back home, we use it as oral treatment. Okay. But for some patients who are actually very good, or they're not taking very high hematogenicity chemotherapy, you can always just give like Granisetron. So it depends on the patient and what regime you're using actually. There's no hard and fast rule. Either one is okay for me.
Okay. We actually have a chemotherapy is a related question then. So the question is, can the Xeloda given for renal impairment patients?
Okay, Xeloda for renal impairment, it depends how bad is your renal impairment. We mainly look at your creatinine clearance. If your creatinine clearance is less than 30, there are no studies to prove Xeloda. There are no studies to say Xeloda can be used for less than 30 creatinine clearance. Okay, anything more than 30 you can use, but you need to dose adjust. So someone with very normal, probably you give 100%. Somebody like moderately impaired, you need to start reducing either like 10%, 15%, 20, 25%. There are a range, and there's no like hard and fast rule how much you need to reduce lah. But generally they say dose reduction for someone who has moderate kidney impairment. Anything less than 30, generally they just say don't give.
Okay. All right. Thanks, Dr. Malwinder. So I think that the next one will be my last questions. We have covered quite numbers of questions here already. So the last question is like, for those patients who are undergoing the gamma surgery, right? Is the risk of nauseous and vomiting similar to those who are undergoing some conventional radiotherapy? When they come down into managing it, what will be a difference in terms of strategy then?
Okay, actually, for someone who goes for this very stereotactic treatment, whether it's stereotactic radiotherapy, stereotactic radiosurgery, whether it's gamma knife, cyber knife, or just a conventional stereotactic radiotherapy, okay, those are very, very small tumors. Okay, so very small tumors, the radiation beam is just directed to the small tumors. The toxicity to the surrounding tissue is very, very minimal. Compared to somebody who actually have multiple brain mets where you're actually radiating the whole brain. Okay, the person who actually having whole brain radiotherapy definitely will have more nausea and vomiting compared to somebody who's actually doing a stereotactic therapy. Okay, but generally, even for anybody who goes for stereotactic therapy or even for whole brain radiotherapy, depends on the patient also. Majority of them will always be pre-medicated with steroids because any brain tumor will always cause edema.
Sure.
Even before radiation will cause edema. So to reduce edema, they'll already be on steroids.
Yep.
Okay, and then by giving radiation will cause more edema. So if whole brain radiotherapy, definitely the edema is much more compared to stereotactic radiotherapy. So most of them are already on steroids, so that is already maintained.
Yep.
Okay, the next vomiting, I would say like probably 80% of 70% of patients don't actually really vomit.
Okay.
Only that 30% who actually vomit because they are already on board steroids, their vomiting will definitely be reduced already.
Yep.
So those person who actually have vomiting, you can always just give something simple like metoclopramide. It already do the job already.
Sure. So it seems like the rescue medication will be adequate for these groups of the
Yes,
patients.
it will be adequate. And the nausea vomiting is very less in stereotactic therapy.
Sure. All right. I think that should conclude for today's sessions already. So thank you, Dr. Malwinder, for the great sharings. I hope that by the end of these sessions, right, everyone will have a take-home message how to manage the quality of life of the patient, especially when they're undergoing the chemotherapy then. So this marked the last sessions for the Medflix 2021. We appreciate your attendance and hope the Netflix have brought a different learning experience for everyone here. So please come back here to rewatch the video later. If you have any questions, feel free to drop us a message and we'll try our best to respond it. Until next time, take care and enjoy the rest of the weekend. Thank you again. Thank you, Dr. Malwinder.
Thank you.